All right, folks, welcome back to House Education for February 10th. This afternoon, we're going to learn about something that in my 6 years on House Ed, I haven't heard much about. And given all of our testimony yesterday about student mental health, designated agencies, it was suggested to me that we learn about the Success Beyond Six, program and how it works with designated agencies. So we're going to welcome two folks from the Department of Mental Health, Laurel Omland and Marianne Donnelly. Please come join us right up here. We also have two members of the House Appropriations with us, and I would just welcome you to ask questions as you'd like as well.
And thank you so much for having us today. So as Chair Conlon said, I'm Laurel Omland. I'm the Director of the Child Adolescent Family Unit at the Department of Mental Health. And with me is Mariana.
Hi, I'm Mariana Donnelly. I am also at the Department of Mental Health, and I am the School Mental Health Practice. School Mental Health,
Coordinator and Practice. School Mental Health and Practice Development Coordinator.
There we go.
It's a mouthful.
It's a good start, really.
Okay, so.
Yeah, you're starting fresh. We know nothing.
Okay, great.
Okay.
I did want to just offer some additional context before I dive into Success Beyond Six. I also had listened in on some of the testimony yesterday and was really, impacted as well by what we were hearing. And it wasn't new information. It was important for everyone to hear what the schools and providers are facing right now. So we know children and families are struggling and having more challenges in accessing the supports that they need. I'm going to talk a little bit about that broader system and also offer some data to support some of the anecdotal pieces that you heard yesterday, and then dive into what is the Success Beyond Six Medicaid program. So if you could go, I believe you all have the slides. So go to the second slide. This is just wanted to touch on briefly the public health model that we use, where we think about what are the needs for everybody universally to understand mental health and wellness. What are the supports that are needed for those who might be starting to show some signs of concern? And then what are those supports and interventions that are needed for those with more intensive identified mental health concerns? And so that's how we think about the different array of our supports and services. Slide 3 gives you some examples of what those look like across our system. And as we think about these, you'll notice the bar on the right where workforce is a tremendous important aspect of this. And right now is one aspect that you heard yesterday is really impacting the ability of each of these layers of our system of care to flow well and really address the needs at the time that families and children need them. So we know that anytime when one aspect of our broader children's system, not just mental health, but all of the child serving entities, when one of those is struggling, it does have kind of ripple effects on others. And I think the challenge that we're facing right now is multiple aspects of our system are having challenges. And so that is playing out, as you heard yesterday, but it is significant in the mental health system. And we are taking steps to address those and to address it at the different levels of care. But those changes couldn't come fast enough, I guess is what I would like to just acknowledge. On slide 4, just a brief introduction. You're probably aware of this, but who are our public mental health agencies? We call them our designated agencies. So on the left is a map of what agencies serve which regions of our state. And then the graphic here is just to give you that longitudinal view of the number of children and youth that have been served through the Child, Youth and Family Services programs within our designated and special service agency. For children's mental health, we have 10 designated agencies, and then we have one special services agency, Northeastern Family Institute, which you might have heard of. So those are all listed there. It is, I think, noteworthy as we look at that graph and the fluctuations. Those are representing children who have been served, unduplicated children. So they might be children served in school mental health as well as other services provided by the agency. And those fluctuations might be about, contracts for Success Beyond 6 Medicaid, but it might also be about the available workforce, because in order to count, they have to have provided the service. So wanted to note that. What we don't see in this type of data, this is, and some other data that we have, is about children who are receiving services. We want to also understand what's the broader need among all Vermont children and youth, and that's where we need to look to more population level data. And unfortunately, that type of data has a bit of a time delay in when we can get the results. So things like the Youth Risk Behavior Survey and the National Survey for Children's Health are population level data that we can look at how children in Vermont are doing, what are their areas of concern, and that can inform us, but it's a bit delayed. I will share some of those though. So if you go to the next slide, this is showing some population level data from the National Survey of Children's Health. This is done through the Centers for Disease Control and Prevention. And these are surveys of parents about their children. And this survey has a broad array of information within it. I just selected a couple of things, but we do look at this. So here you're seeing data from a combined data set of 2020 data and 2021. So really like the beginning and mid-pandemic period. We do not yet have the 2022. We hope to be able to look at that as soon as we can. So on the left, what you see here is aspects of flourishing, and the way that they get at that are asking questions of the parent or caregiver about how often does a child show interest and curiosity in learning new things? Do they work to finish tasks that they start? And can they stay calm and in control when faced with a challenge? And so if you think about those are all aspects that contribute to kind of resilience and ability to function in the face of difficulties. So these are areas that we track and look at. And you can see in that one on the left, about 20% of Vermont children had 0 to 1 of those flourishing items. About 20% had 2, and then 59, almost 60% had all 3. I will note that from the prior 2-year data set of 2018, 2019, pre-pandemic, about 65% were showing all 3. So it's gone down, which I think is notable. And the one on the right, it shows, it looks at making or keeping friends among school-aged children. Again, a really important aspect of social connections. Nearly 73% of Vermont children showed no difficulty, but it is notable that 21% showed a little and 6% showed a lot of difficulty in this area. So that's a flag that we want to pay attention to. And again, those are numbers were better, I would say, in the prior 2018 to 2019 data set, where about 75% showed no difficulty and about 5.4 showed a lot of difficulty. So again, just to give a picture on what the broad population looks like. And then the next one is also from the National Survey for Children's Health. And this is where parents or caregivers reported having their child having a diagnosed mental, emotional, developmental, or behavioral problem. And so you can see that about 30.5% of Vermont children ages 3 to 17 had one or more of those types of problems. And this is up. The prior period of 2018-19, it was about 26.9%, so it's up about 4.4. I would anticipate that that's at least the same, and maybe we'll see higher in the 2022. We're not quite sure. And it is notable when I was looking at this that the Vermont data were higher than what the national rate was. The national rate was about 23.3%, had one or more of those.
23%?
23%, yeah. So if you go to the next slide, we do try to really look at what are the national recommendations and best practices related to the various services that we provide. So this is just showing you one area that we're looking at is the best practices for school mental health. This is put out by the National Center for School Mental Health. And it was a really important document that came out in 2019 that helped guide how we're looking at and really understanding what do we cover, what are we offering, and where are some of the gaps. I would say Vermont has been well situated in providing things that align with the structure of a comprehensive school mental health system. That is not to say that there aren't gaps within that. On the next page, it shows what are some of those core components around wanting to make sure that we have our educators and system trained, that we have a link with families, school and community who are informing how the school mental health systems are working, that there's a need assessment and resource mapping of what exists and where some of those gaps are and how to fill those. You've probably heard a bit about multi-tier systems of support, the AOE initiative, so that's identified in here as well. Mental health screening is a core component, and we can talk about that a little bit later. Use of evidence-based and emerging practices, use of data to inform what practices are you selecting and what impact is that having, and then a look at funding, and we'll be talking more about the funding aspect. The next slide dives a little more into showing just visually what do we talk about with regard to the multi-tier system of supports, which is really a way of looking at the needs for all, some, and a few across academics and social emotional and behavioral needs of students. And this was a graphic that really resonated with me when I saw it adapted from Sherry Hooper, who's out of the National Center for School Mental Health. And you can see kind of where the recommendations are around the focus for school districts across those tiers, and then their partnerships with community partners and how those are a little bit flipped, but truly trying to look at that partnership to meet the needs at those different levels. And then on the right are just some examples of how that is provided in Vermont. Again, we'll talk about that at least under the Success Beyond 6 approach. I do want to just make a note that when we talk about tiers within a multi-tier system, we're talking about tiers of supports and interventions, not students. Okay, so we don't talk about them in that sense. The next slide is just to call out that there are different structures for how school mental health is offered in Vermont and across the country. As you heard yesterday, there are some structures where schools directly hire mental health providers onto their staff. There are also ways that there's an integrated partnership with a local community mental health entity. In Vermont, we fund that through Success Beyond 6 Medicaid. There are also co-located structures where a school might just open up some space within their building for a private practitioner to come in and they bill Medicaid directly or other insurance, or provide it through telehealth. And then there's just that coordinated piece where they're just referring out elsewhere. And there are pros and cons to these. I would say, you heard some yesterday from some of the school leaders about their need to do more of that internal approach because the integrated partnership with the community wasn't able to fully meet their needs, and still acknowledging that there's a difference because when hiring and providing mental health services, it's helpful to have those overseen by mental health experts and have that layer of access to supervision and other mental health supports. And I think that can be a challenge when it's solely internal, and so something for us to think about. Okay, so the reason you asked us here was to talk more about Success Beyond 6. I will just start by saying some people question why it's named that. And I'll say we had a program also called Success by 6, which was our early childhood program. And so wanting to acknowledge kind of what needs to happen before kids enter school, and then what needs to happen for children in school, so that there's not a cliff or an ending of supports and services for families. So this was actually authorized by the Vermont legislature in 1993, and the intent was to reduce the cost burden to education and the state by leveraging Medicaid, by leveraging that federal share to cover services for Medicaid enrolled students. It really is, it's the name for the funding mechanism that we use, and it's driven by local partnerships between a local educational authority, whether it's a school or a district, and their local designated agency, the mental health agency. And so there's a coming together. I think of it as schools have their own unique array of supports in place. They have a certain FTE of school counselors, school nurses, school psychologists, and then they look at what are their needs. They're using their data and talk with the designated agency about how can Success Beyond 6 help kind of address those other gaps to meet the full needs of their students. And so it does look different.
For students.
Yep.
We're talking about Medicaid eligible students.
Primarily, but I'll talk a little bit about that as we go. Because we've tried to make some adjustments to the funding mechanism to see where we can offer supports more broadly. It is still Medicaid funding. So that's the key piece here. So the process is, those local conversations happen, and there's a local contract that's established between the DA and either the school or the district. And within that contract agreement, there's identification of what can be covered through Success Beyond 6 Medicaid. And then sometimes there are additional supports that the school wants from the designated agency, and those are also included, but those can't leverage Medicaid. So for example, if they wanted the DA to provide additional training to their staff on mental health topics. Once that agreement's in place, we have a process with Department of Mental Health and the designated agencies whereby we establish a contract with them for what are the expected services under Success Beyond 6, looking at what they've agreed to locally and establishing that within our agreement, what local match needs to be paid to be able to draw down that Medicaid and the installment of those payments over the course of the fiscal year. And then what are the expectations for providing those services? So tying it to the Medicaid standards, their reporting requirements, and their outcome measurement reporting with us, and then our oversight. And so it is that state to DA agreements driven by the local agreement between the school and the district. And essentially, the Success Beyond 6 Medicaid is the Medicaid authority sits with the Department of Mental Health. It is around 72 million at this time. But the budget it's not in our budget in that sense, because the state match to draw down the Medicaid is coming through these local agreements. So it's the district or the school providing the clean match to draw down Medicaid. I'm going to pause there in case there are specific questions, or I can keep going.
Oh, well, no, actually, I just did. So what you're saying is that it requires the state match to draw down federal Medicaid dollars. Correct. That state match is largely what local districts are putting in to their contracts as their share through Success Beyond 6.
Correct. And my understanding is that for those services that are provided to students who receive special education, there is a process whereby the local entity can then get some reimbursement from the state ed fund. So it's not fully on.
That's correct.
Chair, could I ask a question?
Yes, Representative
Could
Mahoney.
you give us a sense, I understand from what you're saying that I'm Mark Mahoney, I'm with the Appropriations Committee. I understand that a local school district can, as part of its contract for services that are not covered by Medicaid, including services for kids who are not eligible, Medicaid eligible.
Yes.
Can you give us a sense of what percentage of the kids are eligible for Medicaid? I mean, what percentage are we talking about statewide on average?
I don't know that I can give you a percentage off the top of my head. That's something we can follow up with. I can say that about over 3,000 students are served under Success Beyond 6 Medicaid. But that is something that we can get back to you on. I also, my understanding is, again, it depends on the district, but the majority of the students served through the designated agencies in their contracts with the local school or district are Medicaid. There's a smaller number that might be commercial or not covered under Success Beyond 6.
Do most districts or a lot of districts contract with the local agency to provide services regardless of Medicaid eligibility? I'm just trying to get a sense as to whether non-Medicaid eligibility.
So I think that the answer to that is, as you said, district by district. And for example, some districts will contract a whole alternative education program that will serve a mix of kids. We got a whole bunch of questions here. Well, we have time. Yes, go right ahead. Representative Taylor.
So just a question, and I don't know if this is tied into the Medicaid funding or not, but there's a question regarding the designated agencies and the reasoning behind having a geographical area for those designated agencies. For towns like that I represent, which are border towns, it would benefit them from being able to maybe reach over into Franklin County. I know that everybody's having the shortages right now, but to be able to cross borders out of these might be a solution or help a school district who's in need. So I didn't know if that reasoning was tied to the Medicaid for these.
I believe it's tied to the designation rule and how it was established originally. And it is an area, as you heard yesterday, it is challenging because designation regions don't line up cleanly with AHS districts or school districts. So the DCF offices for child welfare concerns might vary. There are some districts that have to work with multiple designated agencies and multiple AHS districts. And that's something that we haven't been able to figure out a solution to. That said, there are situations where some designated agencies can provide services to people from a different region. There's some allowability of that, I guess I would say. Similarly, as we get into talking about what are the different programs under Success Beyond 6, where a designated agency runs a therapeutic school, they will receive students from various districts also.
I just want to make sure, yes, Representative Austin?
How do school districts know when they're building their budget, how much to put in for mental health services? I don't know kids coming in or, they may know who's in their school, but.
I probably am not the best person to answer that question. My understanding is they look at their data, they look at the trends, and that likely informs it. I know that there are a lot of conversations that happen between the school and the designated agency as they're planning for the next school year. But I'm not an expert in how they build those.
And it fluctuates throughout the year. As students move around, I mean, it really moves quite a bit.
Slide 12, I believe, shows the breakdown by recent fiscal years of how many public schools or supervisory unions or districts had some Success Beyond 6 within them. And then how many had school-based clinicians? And the reason I'm calling that out is because that's a broader type of role that I'll talk about in a little bit that might be able to help address across the tiers a little bit more because of how we have things structured. So in 2023, schools and districts contracted with DAs for Success Beyond 6 school mental health services in nearly every district, about 94%, and about 64% of public schools. That public school number does not include the additional 13 independent schools that they provide Success Beyond 6 services in. And you'll note on the bottom, the tally of how many public schools in Vermont, it excludes the tech centers.
Excludes.
Excludes, correct. The next slide shows what are the different broad types of programs under Success Beyond 6 and what are their Medicaid funding structures. So we have school-based clinical services, which uses a monthly case rate. I'll talk about that in more detail. We have school-based behavioral services, which are still using a fee-for-service Medicaid structure. And then we have the CERT therapeutic schools. CERT stands for Concurrent Education, Rehabilitation, and Treatment. And those have a daily rate that's set uniquely for each one. So I'll talk about those in more detail.
Does the clinical services include social workers?
Yes.
Yes.
Yes. So the next slide talks about clinical services and what's in those. These are often known as school social workers, school-based clinicians. They used to be called homeschool coordinators. I don't think that name is used as much anymore. Typically, these are master's level or licensed clinicians. On occasion, especially because of inability to hire and fill with that type of credential, they might have a bachelor's or a master's level intern. And if it's that, then they're only providing services within the scope of their ability. So meaning that either they're under supervision or they're not doing the therapies, they're doing more of the supportive counseling and service coordination. So on the left of the slide, you see what the service array is that's covered under this category of clinical services. So they can do clinical assessments, individual therapy, group, perhaps family, not typical in a school setting, but they will do family work. They will work with families They can do the supportive counseling in groups or individually, service planning coordination, really trying to make sure that the services that are happening for the youth in school and out of school are coordinated. They can provide mental health consultation, so either about a specific student, so they will often be a part of education support teams. And they can also provide consultation and just be that kind of mental health expert at the table, joining others that exist around some of the system-wide, school-wide work, the multi-tiered systems of support teams, thinking about school climate, et cetera. They will provide in-school crisis response to an extent, and then tap with the emergency services of the designated agency when needed. Family support I mentioned, and a health and wellness broad category. So the way this is funded, as I said, it's a case rate. And so we're working under our 1115 global commitment to health waiver with Centers for Medicaid and Medicare Services, which allows us to create alternative payment models, alternative from fee-for-service, essentially. And so what we were able to do was create a monthly case rate and establishing a rate based on some historical fee-for-service utilization and payment structures. So we have a per member per month rate that's set for each school, and then it's adjusted depending on whether that school is an identified and participating PBIS school or not PBIS. And the reason we do that is to adjust slightly. There's a target caseload set. So for each month, they have to meet a minimum service threshold per student, Medicaid enrolled student that they serve, and they have to serve a target number of Medicaid enrolled students in order to draw down their case rate to the full extent. And if they do that each month over the course of the year, that will cover the costs of that school-based clinician. So the reason we reduce the caseload for the PBIS and engaged schools is to really allow more fully, but for all of these, the case rate allows some flexibility to, in addition to doing that direct intervention with students who have identified needs, they can participate in those other school type of mental health related needs and activities. So they often provide consultation to teachers around classroom and classroom management, how is that going? Or, as I said, participate in educational support teams, which might include students who aren't necessarily on their list of clients to see, but are consulting about what are those particular students' needs and how do we think about responding to those in other ways. So it's that flexibility that a case rate offers, but it's only to a certain extent. And I will say over the course of the pandemic and the conversations that we've had with the directors of these programs, they've talked about the increasing intensity of need among the students that they've been serving and the increasing number of students who have need. And so that's putting some pressure on their ability to do that kind of broader systems work. They're seeing more kids with shorter timeframes of being able to see them. So sometimes it's even challenging them to meet that minimum service threshold to count under their caseload. When the pandemic first hit and there was school closures and a lot of reductions, once school reopened, reductions in, with staff either being out sick or students being out sick, they just weren't sometimes able to hit their targets to draw down the caseload. And so we made some adjustments under the COVID relief to be able to lower what some of those expectations were so that they weren't having a financial burden and they could keep their clinicians in place and still be able to meet the needs of students, even if they weren't hitting that more standard threshold.
When you say draw down their caseloads, you mean draw down their
Medicaid. Yes, sorry. Any questions about that structure?
Let's go.
Just highlight really quickly that part of that change in the funding there, doing the case rate is so that it's opened up those services, just like what you all were asking, is opened up to more than just Medicaid students. They're impacting the school system more globally and the climate in there and helping school teams with transitions and, various other things to sort of mitigate some of the mental health things that we might see from the students otherwise.
And when they're doing that, those aren't necessarily counted students. So we don't necessarily have the data of how many students can they impact with that more flexible use. And so that is an area of conversation about administrative burden and trying to track that impact versus wanting to just be able to have them be available to provide those types of supports. So what we are able to track is students who are open to them as a designated agency and providing, direct interventions with. The next slide talks about the school-based behavioral services. You might know this as the behavioral intervention programs. The service array is there on your left. I think you heard yesterday about some of this also from Washington County, from Tiffany. So the types of staff who provide these services include often a board-certified behavioral analyst or a master's level clinician. And then they would supervise behavioral interventionists who are typically bachelor's level. On occasion, agencies aren't able to recruit for that level, but then they expect them to be a registered behavioral technician and go through that additional layer of training. And then they can provide the functional behavioral assessment, develop the behavioral support plans. This is about supporting specific students with very high intense needs within a school to help them be able to remain in that school. And then trying to help taper down that level of intervention so that perhaps they can not have that and still be successful in the program there. So they offer the community supports, which is really the behavioral intervention. So that's where the one-on-one or perhaps a behavioral interventionist might be supporting a couple of students at a time, depending on where they are in their transitioning. They can also provide some behavioral consultation, again, student-specific or perhaps more system-wide or classroom-specific. And then there are some programs that are really particularly focused on serving students with autism. So those are the
Just a quick question, I may have missed it, but you said that these folks are generally your clinicians or your behavior analysts, and they oversee behavior interventionists.
correct.
Are the behavior interventionists employed by the school or employed by the DA?
In almost all cases, they're employed by the designated agency.
Okay, but there are also a separate staff of BIs that may be employed by the school system.
Correct. There has been, I've seen over the years, in one region, there was a model where under this program, they had the clinical or the behavioral kind of master's level clinician supervising the school employed interventionists or para educators, trying to help increase their skill set. I think, I think that was working to some extent in that region. I think there was also a recognition that there's just an additional layer of training expectations. We have some minimum standards for the providers under this program of what their training needs to be and the amount of supervision that they receive. And that's not necessarily the same applied for the school employed staff.
Within a school system, you might have basically two parallel sets of services, the school employed BIs and their supervisor who are serving non-Medicaid students, I guess maybe, and then the DA provided clinicians or analysts and their BIs.
I don't know how often that actually happens. I am aware that there are, within those local contracts, schools will contract for the BI for the non-Medicaid enrolled student. They're just not able, yes, but they're just not able to leverage Medicaid for that.
Throw around the acronyms here, can't we?
I think what you would see more often is a behavioral intervention program in parallel with the para-educators whose focus might be more on the academic side, so that there's not the overlap or duplication.
Thanks.
So these are fee for service, as I noted, and some designated agencies have created kind of different ways of providing this. Washington County has been really creative in what they call a pod model, so that schools can decide how much of the board certified behavioral analyst time do they want to purchase, how much of the behavioral interventions do they want to purchase, and kind of how they package that. If they want more consultation to teachers and broader school, or if they want more of the intensive supports for particular students. And then there's a PBS consultant model that's provided in a different region. Again, really bringing that kind of behavioral consultant approach to the school. And then the last program under Success Beyond 6 is what I mentioned before, CERT, or Concurrent Education, Rehabilitation, and Treatment. Really think about these as the therapeutic schools provided by DAs. So these are Agency of Education approved independent schools with Success Beyond 6 services layered within it. So you might know these as the Baird School, Gene Garvin School in Chittenden County, Laraway. Washington County has 2, the choice programs for middle and high school. And then there's a small program in Orange County run by Claire Martin Center called East Valley Academy. And that's all that there are, so there are 6. This, as I said, it's kind of that layering of independent school with therapeutic approaches, and they really have not just the mental health providers in there, but they're providing some additional support, training, consultation to the education staff as well. There's a daily rate that's established annually for each of these programs based on their budgets and costs, and we do that in coordination with the Agency of Education so that they're setting the independent school rate, we're setting the Medicaid rate for the treatment services. And I'm not sure what else to say about that. Okay. The next slide is really just to highlight what are some of those clinical practices that we have through our school mental health Success Beyond 6 program. So these staff are using cognitive behavioral approaches. There's been a strong push around making sure that the programs are trauma informed and understand trauma responsive practices, and even providing trauma specific interventions. We, in recognizing the high levels of anxiety that were present, both anecdotally and in the data, have also tried to support some anxiety-specific treatment approaches. Family systems is a strong focus as well, motivational interviewing, et cetera. So you can see what these are here. There's also a focus within these programs around providing quality supervision to their staff and using reflective supervision practices. And then there are clinicians, especially who might have additional skill sets around dialectical behavioral therapy, narrative therapy, parent-child interaction therapy, et cetera. So the next slide, we get into what is the monitoring and oversight of these programs. Because these are Medicaid, they fall under the Medicaid standards and oversight that Department of Mental Health provides to the designated agencies. So we have a provider manual, which lays out the expectations for the services, the documentation, the provider credentials. There are minimum standard chart reviews, which include these services. And then the agency review and designation review process includes these as well. And that's where we hear from people who receive services as well as stakeholders, especially schools, about how is the agency doing. And then there are some additional practice standards layered on top of those broad Medicaid standards that are specific to Success Beyond 6. So that's expectations, as I said, for the supervision, the training, as well as their reporting. So there's more additional reporting expectations for these programs beyond what they have to do in general around encounter data and financial reporting. And then we track their, we have the contracts that are established with them. We track their spending throughout the year. We make sure that they are submitting the match payments to us, and that's in line with what they're submitting for claims for Medicaid. And if it looks like they're running hot or, where they are in relation to what we've contracted for, we might need to make some adjustments to that. And then, as I noted before, there's an annual review of the CERT and school-based clinician case rates or daily rate. The next slide shows what are some of those outcome measures that we look at. So again, taking that results-based accountability approach of how much, how well, and is anyone better off from these services. We certainly track how many students are served and in the different programs, how many staff are a part of this and what role and in what setting. And then how much of the dollars that are associated with this. As far as how well, they all conduct school satisfaction surveys. And then there's an annual reporting process that we then translate into some annual reports. And then as far as is anyone better off, we previously had been using a child behavior checklist, but switched and have been over the past maybe 5 years using the Child and Adolescent Needs and Strengths tool. And that's something that we're using across our children's mental health system with the designated agencies, but we have specific reporting from the school-based programs around this so that they're submitting data from this tool and showing us what the data looks like in the fall and then what it looks like in the spring so that we can kind of see what are the needs of students coming in and what do they look like towards the end of the school year. Of course, we know the school-based services are not the only services contributing to what's showing on those tools, but we hope that that's a factor. So to show you some of those examples, there's a slide here with how many students have been served under Success Beyond 6 over the years, and just noting fiscal year 21 and 22 have had some impacts due to vacancies, as well as reduction in local contracts. So that's a trend that you can see there.
All right, so in here you're noting that in FY 21, 22, numbers are down probably due to COVID and staffing issues. But but that doesn't necessarily translate to fewer kids needing services.
No,
So
it does not.
what becomes of these kids?
I think that's where the school-based mental health staff are trying to work with the schools to figure out what else can happen. And the local designated agency is also a resource, but we also know that that part of the system is stressed. So I think that's where we're also trying to make sure that we are thinking about not just kids as their needs are increasing, addressing those, but are we also able to get somewhat upstream and address more emerging concerns, and what are the parts of our system that can do that upstream work also?
And I think that's part of sort of what we heard yesterday in the testimony. It's just these kids who, because of your own, or of the DA's own issues with staffing and funding, ultimately the school is responsible.
I think that's true when it comes to the school day.
Yes.
I think it hits other parts of our system as well. And there was a slide yesterday about the levels of care and the challenges at those levels of care. And I do think that that's where some of the different aspects that we're trying to put into place around building up mobile crisis so that there's more community-based response to crises, alternatives to emergency departments so that kids and families have a different place to go for supports. But we do need to be able to fill roles to provide the more traditional therapies. So that is the next slide, which shows what the trend has been related to the designated agency and SSA, Special Service Agency, vacancies. This data is prepared by the Vermont Care Partners, so it's from the designated agencies. But there's a work group made up of state department representatives and designated agency representatives to really look at the workforce and what are the different initiatives and approaches to try to recruit and retain staff. So
It's a very unfortunate change with the 8% increase in Medicaid reimbursement, which was seen as really making a big difference. And I think for many, it did make a big difference. And then, of course, we had inflation of the
yes. Yes. The next couple of slides were just to share what we are able to see from some of their outcomes reporting. So this is from the Child Adolescent Needs and Strengths tool. This is a statewide look. And in the first slide is about the life functioning domain, which is kind of how the CANS tool breaks things up into different domains. And then within each domain, there are different items. And so this, we can see in the dark green, what were students' needs at the beginning of the year, and then where were they at the end of the year. And then we try to look at change between those two. So really, this is a tool that the providers complete based on input from multiple sources, the child, the family, the school, anyone else who's engaged working with them. And then they capture that rating about, is there an identified need? Is there a history of a need? Is there no presenting need? And is there a need that needs immediate attention is kind of how they rate it. So you can see where some of the areas of concern were, and then also some of the areas of improvement. So around family discord, sleep, school behavior, school achievement, and then some improvements in those areas towards the spring. The next slide also gets at risk behaviors. We've shared and looked at these together with our school-based program directors, because again, this is kind of statewide. They might see their own programs, but to see it at a statewide level, this resonated with them from what they're seeing, concerns around suicidal thoughts and behaviors, concern around non-suicidal self-injury behaviors, dangerousness to others. And those are areas that they really are trying to address and also partner with those others who might be involved in addressing those, whether through outpatient services or other parts of our system. And then the next slide gets at more of the behavioral and emotional domain items. And I would say the high items that we see here, anxiety, ADHD, and adjustment to trauma, have been consistently high areas, as well as anger control when we look at this over time, with some improvements, but those are where we are trying to address kind of workforce development opportunities to focus on this. So I don't know if it would be helpful for me to share a little bit of the work we've been doing with Agency of Education, or if we want to just kind of pause and talk.
We will pause and see if there are questions. Go ahead. So we'll look around quickly. Yes, Representative Benier.
I've got lots, but to keep it to the point, just about the current slide, it's looking at the difference between the fall of 20 and the spring of 21, right? This improvement from dark blue to light blue.
Yes.
By 21. Yes. And thinking back a million years to that time, vaccinations were coming online, summer was coming, we were assured it was going to be, do you assume or do you know that this then got worse?
We are still in process of reviewing the more current CANS data, so I can't answer that.
Representative Williams.
Yes, thank you. Do you see geographic trends like this part of the state or this district or that group of people?
As far as the delivery of the service or the needs?
No, the need.
Again, I guess I would say we try to look at this on a broad level because of where our role is and how do we think about what are the supports and needs for the school-based providers across the state. Where there are particular areas of concern, those have been conversations with us about like, how is it going? What do you need? What's going on? We can see this data by designated agency. The numbers get smaller depending on what region we're talking about. And so it's, how else would you respond to that?
Yeah, I think, and that's something that I think that the local agencies look at themselves. They all collect this information and churn it for themselves and take a look at, trend lines and what's happening in their area. So I think they're probably better suited to answer that, and we try to keep it at the state level and figure out what's happening statewide.
Representative Benier.
Sorry, I think this is a follow-up to Representative Williams' question, but I'm thinking back to the first third of your presentation when you were talking about how Vermont students were doing worse than the national level, I think you said. And I'm wondering if you know about any correlation between the duration and severity of lockdown and what we're seeing as results, whether it's because the kids are out of school longer or because there was an insufficient number of providers. Do you know whether that state-by-state comparison has been made?
I couldn't speak to that in detail. No, I do think it's notable to think about, especially for the younger kids, who are just entering kindergarten or in those earlier years where they might not have had that opportunity to really experience the routine and structure of school. And anecdotally, having heard from both schools and our school mental health providers about the types of behaviors that they were seeing among those younger kids, there was more dysregulation. And I think really how they've understood it and we've talked about it is it's not problem behavior, right? It's the dysregulation and the distress that those kids are experiencing and also are experiencing around them. And so kids' behavior is kind of a reflection of that. It's also about how are the adults doing in their home, in their community, in their school. So I don't know about length of time of lockdown. I certainly couldn't speak to that. But I do think that regardless, how we understand what we're seeing is what's important, and how can we best support the adults in school, out of school, in our own homes, in our neighborhoods, and the kids. So it needs the both and approach.
Just want to get a question that came up, or a concern that came up in the testimony yesterday, and this is back to the boring topic of Medicaid funding, but that it was implied that we are perhaps leaving a lot of money on the table when schools take on the role of providing services that GAs have been unable to provide, and therefore don't have access to that Medicaid money. Is that an accurate statement?
I don't know that I could say a yes, no to that question. I think what I could say is it depends. It probably depends on what is the fund source for how schools are taking on some of that. If some of it was with COVID relief funds, the ESSER dollars, that is federal funding. So I don't know that would be a difference necessarily from the Medicaid federal funding.
Meaning that if they're using ESSER funds to provide these services, they may not be eligible for federal Medicaid funds.
Definitely not, because you cannot use federal dollars to match federal dollars.
Yes, Representative, let me have Representative Butts, you had a question before I go ahead?
This is similar to Rep. Minger's question, but how much did we drop in school achievement during COVID time, and how that correlates to a lot of the behavior disruptions and anxiety?
As far as what's on the CANS tool, or?
Yes, or how different is this during COVID times than normal times? Is there a correlation for increase?
We could get back to you on that. I can speak to it. I can look in what we have from prior CANs, pre-COVID time and now. I also think Agency of Education might be able to speak to achievement in a different way than CAN.
Representative Austin, do you want to miss you?
Yeah, I'm just wondering what where like prescribing doctors, psychologists or psychiatrists come in here, because it looks like, the top areas of concern would also need treatment with medication in order for those students to access.
Yes, so.
Skills.
Apologies.
Yeah, no, go ahead. Thank you.
The presence of attention deficit or anxiety or depression on the scans doesn't imply that they're not receiving treatment. Okay. So you can still take into consideration that they are in treatment, receiving medication, but we're still acknowledging that it's an area of need for them. Medication and medication oversight is not a part of our Success Beyond 6 programs, but it is something that is often happening concurrent through the designated agencies or perhaps a private provider. I could speak very briefly to a new federal funded initiative that we have to be able to increase access to child psychiatry, because that we know has also been a gap across the country as well as here in Vermont. We have a HRSA, Health Resources Services Administration funded federal grants to provide psychiatric consultation to primary care providers who are working with children with mental health concerns. And we just stood it up in June, and it is being used and is, we hope, going to start to have an impact in providing some relief. Because we know that sometimes kids get referred to psychiatry and sit on a wait list, when maybe the person who's making that referral could get some consultation and be able to continue to manage their needs and then save those openings with a psychiatrist for those kids who have a more intensive need for that direct service.
And can there be telehealth across, let's say, the United States in terms of that consultation? Or is it only with Vermont providers?
If we're looking to think about sustainability, it would likely need to be Vermont providers or Vermont enrolled, if we were looking to Medicaid or other coverage. Right now, I think they're all Vermont providers.
Representative Lumley.
Thank you. Thanks for letting me sit in. I am really struck by this figure of designated agency and vacancy, or the numbers, 441 in 2019 versus 1,077 by 2022. And as a legislature, we have appropriated money not only to increase the salaries of designated agencies, which was already discussed before and has been kind of eroded now by inflation, but also we've invested in workforce development, training scholarships and or forgivable loans to students who are pursuing these. This just feels like such a crisis to me, and I can't tell you how many constituents I've talked to cannot find, especially child therapists, but who have also stayed in the emergency room. And I'm just wondering, how have we just been kind of throwing, do we have a shot at getting this right? Like, really boosting our capacity to provide the kind of mental health care that we clearly need? I'm just afraid.
That's the big question.
So one comment that I should have made about this DA SSA vacancy chart is it is across all of their programs. So it's developmental services and mental health, and where they provide substance use, also those. What we see, again, from data provided by Vermont Care Partners is there's been some fluctuation. So developmental services will see some increases in hiring, and mental health will have more vacancies, and then it'll flip. So it does feel a bit like a 2 steps forward, however many steps back, where they will hire positions and start to fill and feel good, and then they have turnover and lose people. I also know from some other both initiatives and conversations that the experiences we hear are either they just aren't getting applicants, or they have applicants and they schedule interviews and people don't show up, or they offer a position and the person's very interested and then they turn it down because they can't find housing. And that certainly we've heard from people coming from out of state. So I do think that there has been some positive impact with retaining many staff and being able to offer incentives for career development for those staff, I think has been valuable. I had an opportunity to speak a couple times this winter with some folks in a graduate program to really both say thank you and the importance of joining this field. So I continue to be hopeful that we can get there, but it's really hard, and it's I think difficult to hear the stories of families who are waiting and are desperate for some supports. And so that's where we are trying to think about all the different ways that we get at that workforce, different service options. But even as we think about different service options, there's a question of will we be able to fill those? Like as we're trying to develop mobile crisis, I think that's an area that we're all a little concerned about.
And just one quick follow-up. So we about the mobile crisis, because you brought that up earlier, and I'm just wondering, are you envisioning mobile crisis actually responding to some of these school issues that this committee has heard about, or?
I will say that we know already the emergency services teams of designated agencies, when they can, are responding to schools. They certainly are also responding to schools after an event like what happened in Montpelier. We know we have a pilot program for mobile response and stabilization services in Rutland, and they have been responding to schools also. I think it is a matter of being really clear about what is a mobile crisis service and how does that differ from other types of services, like what's their role and what's not their role. And I think that's continued dialogue with schools and others. And if it's not mobile crisis, then how can that need be fulfilled?
Representative Brady?
Related to Representative Blumenle's question, when we're talking about all these vacancies, give me some rough idea of what level of qualification or degree these positions are and what kind of salary.
I think we might have some data with that. It is a range, right? So when we talk about developmental services, there might be more, bachelor's level type roles, as well as some higher. Within mental health, again, it is a range. There are clinical level as well as bachelor's or supportive.
But we're generally always talking about a 4-year degree minimum. Provider in these necessarily?
Not necessarily, no. It depends on the role.
I'll just say, I'm trying to get in another designated agency here next week, and I think they would actually speak to that question. And related to that, again, I'm sure, would you agree that it's been a little bit challenging with the big RFS money that school districts have received, and if they've begun sort of building out their own mental health services, that's put even more pressure on the DAs in terms of their hiring challenges?
I think it is. I think it's an area of needing to fulfill the need. It's understandable. And there's an influx of federal dollars to be able to address the immediate impacts of COVID. In some areas, those have happened in partnership with the designated agency outside of Success Beyond 6. I think, I am, and others of us are concerned about what will happen when those federal funds end. Because we know that the impacts don't end that quickly. We're going to be seeing those for some time. So those are conversations that we're having.
I think that the big question, as we looked at that time coming, and I think what we heard yesterday from the majority of the superintendents was, we don't necessarily want to be in this business. But we found ourselves having to be, because when we can't get the service from the DA, we still have no choice but to provide it. And I guess, would you mind offering what you think is the roadmap out of this situation? And I would say, feel free to say it's going to take a lot of money if that's the case.
I actually might point to some of the work that we're doing, the Agency of Education, both through Project Aware, which is a federal initiative, but also just really trying to think more broadly about reform around school mental health. As I talked about in the beginning, kind of those core components of a comprehensive school mental health system, I think there are areas we can continue to strengthen. And it really is getting clear about how do we have kind of access to core mental health services around the state. There is a strong push, as you know, local decision-making is a component of schools. And so the designated agencies are available to partner with them, but it is not you have to partner together. And I think the more that designated agencies are able to actually be responsive and have the staff to meet what the need is, I think that can strengthen that. Sorry, I'm trying to get clear in my head and
It's a lot.
I'm asking you to solve a major problem in the next 5 minutes.
the phrase "it takes a village," it comes to my mind, right? I think addressing mental health needs is partly met through the mental health system, but it's kind of a whole system approach, right? It's all of us, who we are as people, as well as who we are in our roles. And how do we recognize and support and act in the ways that we want to see this come together? That's idealistic, I understand, but do you want to add?
I just think that when you talked about the upstream work and starting to focus more upstream and where are we seeing challenges for children earlier on, and students in general earlier on, and how do we shift things so that they're not struggling for so long on their own and then it explodes into a larger issue. And it's really hard because part of doing that work means that you aren't going to address all of the crises in front of you right now. You're going to have to put some of them on hold and prioritize and go upstream and like try to fix the bridge where folks are falling in.
So I get my stream geography. Are you talking about we need to be having
earlier
quality childcare?
Yes. Well, I mean,
among other strategies.
That's very upstream.
Yes. Yeah, but I think even just in the school in general, that's part of why we've been working on, universal screenings, the universal mental health and social emotional learning screenings to try to get at where are kids, how are they doing individually. We see the kids who are exploding and really loud, but what about those ones who are internalizers? So they're not exploding with behavior, but they are suffering in silence, and there could be, it could escalate and become a bigger issue down the road. So are there some other supports that can be offered earlier instead of the really intensive level of supports? How can we, through educational support teams or others, think about ways that adults in the building can connect with kids? Are there some groups or skills activities that they could be a part of? And as we build up their skill set, their resilience, their feeling a part of the school community, having an adult that they trust and they can connect with, sometimes that can ward off the need for more intensive services down the road. But as Mariana said, it's both are in front of you. And in our immediate.
Yes.
In our immediate. And our adults in the building are experiencing increasing need, and they're in crisis too. And so how do we regulate those folks so that they can have a clearer picture of what's going on and where to address things? And then how do we move some of that work upstream so we don't have so many kids in crisis?
I think some of the ESSER funds that were directed towards supporting educators is one area. We know, as we've talked about, kind of that care of the caregiver, that applies to educators also. So that's an area that I think is important to continue to think about. And I'm not talking about, EAPs, like, of course, those are important, but it really is like in the moment in schools when things are getting challenging, do educators have someone to help kind of think through, how can I approach this differently? I think that can be really beneficial. These are areas that we've been thinking about and talking about with Agency of Education and trying to bring some resources forward to address. Other things like providing training for educators around mental health related topics. We've had some resource to be able to do that. And I would say they're stressed. Their availability to even set aside time to engage in that, I think, is challenging, even though they really want it. So it's not to say that there's not interest. But we do have some either federal funded or other options for schools to participate in, mental health first aid training, for example, suicide prevention training, how to be a trauma responsive school. Those are some different options that are out there that I think over the long term can really benefit. Sometimes it's hard to prioritize that time, again, when you're not able to staff all your classrooms.
Yeah. I think I'm going to let you, if there's some part that you really want to make sure we heard today, but it looks like there's a lot more to the presentation.
I think we've covered most of it. I would say there is an aspect where Centers for Medicaid and Medicare Services put out a joint bulletin with SAMHSA to talk about funding for school mental health. And it struck me when it came because they were basically saying there is no single funding source to do this. Schools and providers need to think about the different ways of putting together various funding sources to meet that need, local, state, and federal. And so we did some work with Agency of Education with input from our local schools and providers to look at what does that actually look like in Vermont? What are those different funding streams? And created a document to try to lay out what those are. And from a decision-making perspective, when you identify a certain need at a different level of tier supports, what are the options to fund that? So that's something that we've made available, trying to just provide some transparency and clarity around it. It's complex. We didn't fully understand the different sources that Agency of Education has. They didn't fully understand how Success Beyond 6 works. So it's one aspect that we've also tried to work through. That was just what a couple of those other slides were in the Project Aware, but I think we spoke to.
Well, I don't want to say that we won't have you back to talk more about what you have left out today, and also what we've talked about. And it's like I said, it's kind of interesting to hear that not everybody's aware of what the other one has for funding sources, because it is, especially with the federal government, it's highly complex. Anyway, really, thank you very much for coming.
Sure.
Down our path learning about this.
Thank you for your attention to this. We appreciate it.
If we lose any more committee members to appointments later on today, we'll call it there.
That was really helpful after yesterday's hearing from the schools. This was helpful just to have a sense of what is out there.